had great meetings. My name is Lloyd Jones. I'm a cardiologist and cardiovascular epidemiologist here at Northwestern University, right here in Chicago. And I'm the immediate past president of the American Heart Association. And I am pleased to be joined by my great friend and colleague, Dr. Bob Harrington. Bob?
I'm a cardiologist, chair of medicine at Stanford University, and I'm a past president of the American Heart Association. So looking forward to being here today.
Awesome. So as you know, our topic for today is life's essential aid and intelligent health solutions. So how can we deploy and how can we implement life's essential aid into various settings in clinical venues, community settings, and for improvement of population health. So we thought we would start with just a little bit of a level set. Of some slides on defining life's essential aid so that nobody else has to do that. We all have a kind of a common understanding of where that's going to go. And maybe I'll just go ahead and do it verbally while the slides are coming up. So back in 2010, the American Heart Association, as part of its 2010 to 2020 goals, wanted to pivot from continuing to reduce cardiovascular disease and stroke deaths to now also trying to promote the cardiovascular health of the population. And so, of course, the AHA being a science-based organization and a very metrics-driven organization, they realized that while people say the term cardiovascular health, it had never been formally defined before. And so they asked a group of volunteers, and I was just so honored to be leading that group, to actually look at the literature, provide an evidence-based definition for cardiovascular health that could be measured in the population and in individuals, that could be monitored over time, and most importantly, could be modified. Something that contained actionable items for clinicians, for consumers, to be able to say, here's my cardiovascular health status, I can actually work to improve it, and by doing so, can improve my longevity, can improve my healthy longevity, and can actually hopefully improve my quality of life as I go. So we created a definition of cardiovascular health that really goes beyond, well beyond, just the absence of disease and tries to kind of get at some of the positive attributes of health. So as that unfolded, after publication of defining cardiovascular health in 2010, over the next 10 or 11 years, there were actually 2,500 different publications that dug in on the construct of cardiovascular health and looked at its upstream determinants, its molecular and social mechanisms, its clinical outcomes, and indeed kind of reinforced the sense that it sort of serves as the fountain of youth. It can serve as something that really drives to healthy longevity at any age. And importantly, what I think the literature has also demonstrated for us is that change in cardiovascular health matters. If you work to improve your cardiovascular health, it clearly improves your health outcomes at any age. Now that said, while change is always good, the earlier you improve your cardiovascular health, the better and more sustained those outcomes will be. So this construct, I think, has had a lot of legs because of what I just said about change. But I would say it's also important because, as you all know, we start to talk about risk and risk factors in people once they're 40, right? That's when our equations kick in. That's when we start to get serious about prevention. But we didn't have much of a message for our younger patients, or younger adults. And so we've updated now the cardiovascular health construct to Life Essential 8 so that it can actually really nicely cover that early life period down to as young as age 2 and across the entire life course. And so it includes the original 7 metrics of cardiovascular health, which were healthy diet, healthy physical activity, avoiding tobacco, of course, now extended to include all nicotine products. With the 8th metric, we've added sleep duration as an important component of cardiovascular health. And of course, continuing to focus on physiologic measures, your weight, maintaining a healthy body weight, maintaining the lowest possible non-HDL cholesterol, optimal blood pressure, and of course, optimal blood glucose levels. So taken together, that package is Life's Essential 8. And what we're going to see today, I'm very excited to say, is a number of sort of digital solutions to how we can get Life's Essential 8, again, into our clinical practice, into the community, and into public health so that we really are raising all boats. So with that brief background, I hope the visuals although they weren't there, I hope you got a good sense of what Life's Essential 8 represents. And now Dr. Harrington and I are going to talk a little bit about kind of where we are, where we're going, to set the stage for some wonderful presentations and demos of how you can actually get life-essential aid into the population.
Thanks, Don, and thanks for what I'll call level setting and sharing with us sort of the background behind Life's Essential Aid. There you go, just in time to see Patrick on the screen. Talk to us a little bit about the sense of urgency here. And you presented some data last week at the HA board meeting, along with a graphic that Rob Califf had published in Circulation about a year ago. We're not exactly living in good times regarding lowering the risk of cardiovascular disease and death.
Yeah, certainly a fair statement. So I think you all know that even before the pandemic, we were dealing with the obesity epidemic. We're starting to see some backsliding on some of the key risk factors and health factors in the population. And it's no secret that the reason we were so vulnerable to COVID-19 is because we were already an unhealthy population with too much obesity, hypertension, and diabetes, the major modifiable risk factors for COVID-19 complications. And so that's truly what made us vulnerable, is that our cardiovascular health was far from optimal. And we've only seen that worsen during the pandemic. People, being isolated, disconnecting from their usual sources of care. We've seen marked reductions in population levels of blood pressure control rates, especially in typically marginalized and underserved populations, especially in rural areas. And so we've lost a lot of ground that we had gained over the preceding decade in trying to improve cardiovascular health in many segments of the population. And that will take time to recover. You can't snap your fingers and get blood pressure magically back under control in one office visit or in one telehealth visit. And so I think it's more urgent than ever, honestly, that we focus on these things.
Yeah, and I suspect some of you saw the opening session on Saturday where Rob Califf was part of this, and he reported that we've lost 5 years of life expectancy over the course of the last couple of years. That's staggering. And it really tells us that we need all of you who are interested in tech innovation to help, because this is not going to be a simple solution, is it?
No, it's not. And I think it's important to point out that while overall we lost certainly dramatic levels of longevity, that of course was never distributed equally. It was distributed in very American terms, which is to say, the communities that were affected most were our indigenous peoples, of course Black Americans, and to a certain extent Hispanic Americans as well. Everybody lost ground, but certain groups lost much more ground. And if we try our usual approaches to those solutions, we will widen the disparities even further, because it will help the people who have access to healthcare and who have means, and it won't help the people who don't have access or means. And so digital health solutions might be a way to level that playing field as well.
Yeah, that's why I wanted you to bring it up, because I hope that as our panelists come up and we see some videos about some new technologies that might be a step forward, we have to keep the health equity piece front of mind. And because, as you say, neither the gains nor the losses have been equitably distributed. Final question for you before we have our first panelists come up. Talk about the 2024 goals as we approach the second century of the AHA. You've also led that charge. To, what are we trying to do over the course of the next few years? What are we measuring, and where are we?
Yeah, thanks, Bob. So many of you may know that just before the pandemic, AHA rolled out our 2030 impact goals, which were focused on healthy longevity. A really exciting, I think, way forward. And then the pandemic, and then of course the syndemic that finally kind of came to the fore, came to people's consciousness about the problems of structural racism and the inherent biases in our society. And AHA, to its credit, pivoted in a heartbeat and really said, okay, we can't think about healthy longevity when we've got these urgent crises in our population. Let's retrench. Leading up to our centennial celebration in 2024, AHA will be 100 years old on June 10th of 2024. Absolutely. How can we have our biggest impact leading up to that milestone? And so, in her wisdom, Nancy Brown and the leadership, the board and the other leadership of AHA said, let's create a new impact for 2024 that is focused entirely on health equity. And what that impact goal says is that by 2024, AHA will be a champion for health equity, focusing on improving the cardiovascular health of all people, while also addressing barriers to healthcare access and healthcare quality. And the way we wrap that up is with one kind of simple evergreen statement. every person deserves the opportunity for a full, healthy life. I think that is just such a great, guiding star. What are we doing? What are the specific things we're focusing on within the cardiovascular health focus? Focusing on blood pressure control rates, particularly narrowing the disparities in blood pressure control rates, because when we get blood pressure better, we actually also prevent events very rapidly, right? Because blood pressure is a chronic risk factor, and it's also a trigger for heart failure, for stroke, for cardiovascular events. Likewise, focusing on reducing tobacco use and nicotine exposure overall, but especially reducing the disparities in those things for the same reason, chronic risk factor and acute trigger of those events. On the other planes, we're trying to increase healthcare access, especially by expanding Medicaid in those states that have not yet done so. It's a policy that works incredibly well. And then improving quality by helping especially rural and underserved urban community hospitals to be able to adopt or get with the guidelines programs that have proven not only to increase the quality of care for hospitalized patients with acute cardiovascular events, but also eliminate the disparities in outcomes once those quality programs are in place. So really exciting times.
Yeah, and again, the excitement of having you all here today is the health technology piece. As we talk about underserved populations, as we talk about rural America, and for those, anybody here from California? I hope you voted. In my shame, Don's been giving out the aids, and part of AHA advocacy, I am wearing my vote yes on Prop 31 in California. Make sure that you do if you haven't voted yet. We've got to get rid of flavored tobacco in California. Big Tobacco is trying to block the laws that have already been passed, and given the proposition system in California, we have a chance tomorrow to make sure that we put the law in place. So thank you if you voted already. If you haven't voted, tomorrow is election day and proposition day. Make sure you vote. Your vote matters.
All right, there it is. So
I'm doing my advocacy job.
Well done, very well done. So let's get to our first demo and talk about some of the projects of implementing Life Essential 8. Really pleased to introduce Dr. Jared Magnani, who is a cardiologist and faculty member at the University of Pittsburgh, and he's going to tell us a little bit about one of his projects. Jared, please.
Thanks so much. I'm Jared Magnani. I'm a cardiologist at the University of Pittsburgh, and I have a health services research program which focuses on people who have limited health literacy and develops interventions to facilitate their care and their self-care so that they can improve in their cardiovascular disease management. And I think to me what's really exciting about Life's Essential 8 is that it creates a partnership between us and our patients. It provides metrics so that we can measure their health with them and help them to invest in their own care and in their self-improvement, which happens in the 10,000 hours outside of our clinical practice in terms of how they can engage in behaviors and modify their cardiovascular risk. That's really exciting to me. And technology has tremendous capacity to improve access to information as well as to guide interventions so that our patients can do better long-term with their cardiovascular disease risk factors. I think there are definitely questions in terms of the application of technology to address the risk factors like the Life's Essential 8. I think that one thing that to me is very compelling about the presidential advisory that Don authored was that it places disease in a social context. Really, if you look at the figure where social determinants of health is the bottom of that 8, and at the top you have the whole spectrum of where people live, and that really matters. And so, again, technology has the capacity to build very compelling bridges and to advance care for people. But there are problems that we have to consider in terms of how we apply technology. And the first is accessibility, because I work with a lot of older adults whom I provide a smartphone. They've never had this tool in their hands before. And so my team spends an enormous amount of attention teaching them how to operate this so that they can use the tools that we provide them. And so some people lack that digital literacy. Different from that is health literacy, which is the ability to use information to make informed decisions. Healthy People 2030 argues that it's imperative that we address health literacy and improve health literacy, both at the individual level, but also at the social and institutional level. we have to be committed towards that. So health literacy is different than digital literacy, and we definitely have to make sure that we embed in our design of our technology ways that we can bring tools to improve health literacy and to engage people who don't have digital literacy. The other thing is, when I use a smartphone and design interventions, is this a Swiss Army knife? Do I think that I'm able to launch interventions that can address all the components of the Essential 8? And the answer is, that's complicated. That's going to put an enormous burden on my participants. And so we really try to keep things simple and address their education, their preparation for their medical encounter, and the challenges they might have with their chronic cardiovascular disease in order to empower them and activate them. This is just an enormous question, because you and I are used to using a smartphone. We have like a whole realm of applications that we use all the time. But I think for people who have limited digital literacy or health literacy, that's going to be a challenge. So that's the access issue. And then there's the objective issue, which is this going to be sustainable? Can technology intervene on social determinants of health? How far upstream can you get? And that to me is a really compelling question, because I'm funded by NHLBI, and I launch interventions that are 4 months and 6 months, and then I go away. And I measure outcomes at 1 year, but obviously what I can't do is provide people with solutions to social determinants that are really the most upstream and important reasons for why they have adverse cardiovascular risk. So that is still outstanding to me as a question, which is, how do we do that? And I think that's going to be a compelling challenge for us. Those are some initial thoughts.
Outstanding. I think we have a couple other initial thoughts, and we're going to have a robust discussion. So next we have Dr. Heather Provino, who is a serial entrepreneur, and she's going to talk about some of her solutions to implement Life Essential 8.
Thanks. Good morning, everyone. Heather Provino. By education, I'm a physiologist and started in cardiac rehab. And then I found myself as an accidental entrepreneur and started my first population health company where we used Life Simple 7. And we did that to really evaluate risk and determine where we should intervene with the individual. Now moving on to our next endeavor, we're thrilled to have Life's Essential 8 to actually not just decide what interventions are right, but also help us sequence the interventions in the right order for priorities in an individual's life. Because people are more than patients, and patients are people. And so we want to take all of that, and Life's Essential 8 gives us great information to help combine with the other clinical data available, but also psychographic information, and helps us understand what are the blockers, where are those social gaps, and most importantly, where on that spectrum do clinicians need to start in order to deliver great care well beyond the face-to-face office visit, but in daily life as well. And so I think adding sleep is a really important component. And not that focused on a lot with technology and devices. And so we're able to collect continuous information on all of the social behaviors, but also those clinical biometrics, and use them to inform the sequence of that care, and then allow our clinicians to appropriately nudge in small digestible chunks how to actually work with patients in a day-to-day in their ever-evolving life, not just from the perspective of clinical visits. We also then use it to educate people and their families and their caregivers. And then I think often overlooked is the business intelligence that you can provide back to that care team, the clinical care team, on how that patient is progressing, where they're slipping, and this continuum. I love the circle button, because it is constantly, it's like a dial that you're just fine-tuning, and that's how we're using Life's Essential in technology and delivering equitable care.
Sandy, thank you so much, Heather. And next, Dr. Sabina Gandhi, who's at Loma Linda, and you have a presentation for us as well.
I do, and before we start the video, I'll just do a quick introduction. So, as you heard Dr. Lloyd Jones mention, I'm Sabina Gandhi, a preventive medicine physician in Loma Linda, California, their VA. And we are, just give me 1 second if you would, let's pause it real quick. So the project that I'm going to be sharing, and I have to say this is a privilege and just a pleasure to be able to share our VA DoD Joint Incentive Fund project, which essentially is using the VA's Virtual Medical Center, we call it VMC, and that is a 3D avatar-based learning platform with 2D content available. This was specifically designed for veterans, active duty service members, their beneficiaries, and providers. So what you're going to see before we hit the start button is we're going to showcase 2 areas. Their main lobby of the Virtual Medical Center, and then the specific center that we've been working on, which is the Performance Health and Wellness Center, where we are specifically addressing the risk factors of cardiovascular disease. So for us, Life Simple 7 was a treasure chest because they are addressing the very health factors and health behaviors that we are populating in our space. And so let's go ahead and start the video, and I'll add more as we go along. Thanks. So the avatars are customizable. This is the main lobby. This is the Performance Health and Wellness Center, where in the center atrium we introduce stroke, peripheral artery disease, and what was Life Simple 7, we'll be changing that to Life Essential 8 as soon as we can. The risk factors are the surrounding rooms. This happens to be the healthy weight and prediabetes room. And inside, you can then go ahead and interact with the content by clicking on any poster or what looks like a TV screen that takes you directly to AHA's content, which is unique for each and every room. So in our, for example, our gender differences room, go red, right? We've got the content for women and health disease and heart disease. And so far, we've got about 150 pieces of unique content in our space in the Performance Health and Wellness Center. We're not done yet. The journey continues. And I just want to say thank you. Thank you for providing this content that is the most extensive. It is the most visually appealing. It is evidence-based. And you have made our job in conveying this information to the public, specifically our veterans and active duty service members, even more rewarding because they can actually benefit from it and all the other lives that you're working to save. So thank you for that. And we'll have a nice discussion after.
Outstanding. Thank you so much, Nina. That was really cool. Yeah, lots of great questions asked about that. Great. And now we're going to have several demonstrations, I think. And so, thank you so much.
Good morning. I'm Carla Robinson from Canary Telehealth. And we're going to talk about how we use the Life's Essential 8 in a self-management program for a rising risk population. Just real quick introduction, Canary Telehealth provides telehealth and call center services that are aimed to improve access and close gaps in care, particularly in underserved populations. We're based right here in Chicago, and we've been at this for about 12 years. Some common characteristics of the population we serve, some of the issues we've been talking about today. Many of the patients in our program have social determinants of health challenges, low health education. Many have recently entered the healthcare system through Medicaid expansion. And have limited relationship with the primary care provider and high utilization of emergency room services. So that's the baseline where we come in. We're really proud of some of the results that we're seeing. We're seeing very interesting improvements in blood pressure control, acute care utilization, preventive care utilization, and what's near and dear to our hearts is self-reported improvement on education and confidence in managing their conditions. So let's talk about the program. So many of you are familiar with traditional remote patient monitoring, with the nurse that's monitoring, generally focused on a more high-risk population. But we know that about 20% of folks who are not in the high-risk category enter into that every year. So that's the rising risk population that our self-management program is focused on. It's anchored in a mobile app with automated education and feedback, with the ability to reach out to a health coach as needed, and also to be able to track their readings. So the patients on the program are issued devices pertaining to their conditions, as well as a mobile app. And to the point that was made earlier, we do an onboarding process that helps them learn how to download the app and how to go to the store. And that may be the only app on their phone that they know how to interact with on a regular basis, but we make sure that they do. So they start the program on day one with a welcome that provides them with an overview of the program and what to expect. And then we get to know them. We ask them some questions about their current behaviors and health status that we use to be able to customize content for them. We give them an overview, a video that provides an overview of life's essential aid. That's really a framework for the content that they're going to get over the course of the program. And then we also ground them and make sure that we provide them with information on how to take a proper blood pressure reading. So over the course of the program, they have daily sessions, which is a combination of taking their readings, getting health education and tips, feedback on their readings, as well as feedback on responses to assessment questions that we'll ask them. And they also have the opportunity to reach out for assistance. Sometimes that assistance are social service needs that they have, and we're able to refer them to resources as a result. So just to give you a feel for an example of the types of questions. So people are on this program anywhere from 12 weeks to 1 year, depending on the program. And so there's lots of content that they have exposure to over time. So we're giving you a sample today. So an assessment question might be, when was the last time you saw your doctor? And if they answer that question that, well, it's been a while, we'll provide them with some feedback and education on the importance of their primary care provider and that role in managing their health. Another example, we might ask them, hey, how well did you do in controlling your blood pressure over the weekend? And if they say, not so good, then we might ask them a question, what were some of the contributing factors? And let's say, for example, they say, well, I smoked cigarettes over the weekend. They might get a video that explains to them the impact of tobacco use on blood pressure and even moderate or infrequent use of tobacco, and that the recommended approach is to don't smoke at all. Another example, we'll ask about their activity level and how well did they do as it pertains to the recommended amount of exercise. And if they say, no, I didn't quite hit the mark on that, we ask them questions about why. And they say, and so they have a whole host of reasons. And the content that they get depends on what they say. So that they're getting information and education in the context of an expressed barrier or challenge. Similar around eating. So we'll ask them about salt, sodium intake, and then, so it's a felt need that they're expressing, and then the content is in the context of that. And it's a combination of videos, infographics, articles, and things of the like. So that's the educational approach from assessments and feedback. Sometimes we're also just giving general health education, so we pepper those in as well. So this week they might learn about cholesterol numbers and what that means. On another day, they might get general high blood pressure education. And so over time, over the course of the program, their health literacy and their comfort level with managing their conditions improves. They're getting education overall, but then also very specific to the readings that they put in. So depending on the levels that are reported in their readings, they'll get feedback on what the American Heart Association has to say about that level and what some things are that they could consider keeping that in control. Lastly, the thing we're really proud of is turning people back to their primary care provider. is the app is a great tool and resource for them to get education, for them to just engage in their health. But we really want people to improve their relationship with a primary care provider. So very often the feedback is if they say they've got barriers with getting their medication, we'll point them back to their doctor. So we have multiple use cases in which people are engaging with the app, in which we're delivering them information. It could be a felt need that they are explicitly telling us about through messaging. It could be a response to an assessment question, or it could just be they've engaged with the app and they're getting the health tip of the week. But through a combination of modalities, articles, videos, infographics, and text, we're helping people improve their stance on life's essential 8.
Thank you so much, Ms. Robinson. Really terrific. Our next presenter. So we got some VR. Watch out.
Good morning, everyone. Pleasure to be here. I'm Navin Govind, founder and CEO of Harrington. We're a digital therapeutics company. One of the areas that we work in is taking on heart failure patients that are being discharged from the hospital stay and managing them to prevent them from going back in, which is the classic 30-day readmission challenge that we're all sort of familiar with. Part of the work that we do in this space is to provide patients with different types of monitoring type of digital tools, whether it's their vital sign monitorings or going through QOL surveys, questionnaires, and being able to better manage their health and medication and so on post-discharge. One of the tools that we've been obviously looking at was complementing the paper-based, the mobile-based tools with a newer version of what we are looking at from an immersive sort of an experience perspective. So we looked at virtual reality as a technology, and I wanted to thank Dr. Harrington and Dr. Lloyd Jones for the advisory and the update of LEA, because we used LS7 to risk stratify and understand behavior of certain patients that are that have prevalency of some of these disease states, and we did a study, and I'll roll a video, but just to give you a little bit of a background of the study that we just completed, which was published and presented at the cardiometabolic meeting just a few weeks ago. 26 patients were part of this study at a primary care. Average age was around 70. They were their cardiovascular disease, type 2 diabetes, they were high cholesterol, tobacco abuse, hypertensive. So these patients also were on metformin, they were on certain calcium channel blockers as some of the meds, along with statins. And if you kind of look at the way that this cohort was structured, we had an interventional tool, which was the VR-based and a paper-based tool that was administering Life Essentials 7, and there was a VR component that the patients were provided with their cardiologist coming and speaking to them in the form of a personalized avatar, which was very fascinating because as soon as the patients put this on, they almost fell off their chairs going, "Oh, that's my cardiologist speaking to me." And now we rolled out a lot of this educational material. So it was a longer session, but we're just going to roll this video for you to take a short look at. It's kind of condensed, but it'll give you an idea that this risk assessment tool is actually something that we are looking to extend, and I'll come back to this. So this is the administration of the risk assessment, and here's Dr. Vijay.
Looks just like you.
There are about 437 million people with diabetes around the world. Did you know that out of this, there are about 300 million people in the world who are now in the developing nations? Let's talk about diabetes now and let's get on with Life Simple 7.
I'm Cindy. A lot of people don't know the important facts about blood sugar or blood glucose.
So this is the
To
actual
many of us,
view that the
term
patient
high
is
blood sugar
experiencing and
only
going
makes us
through
think of candy and tablets.
the application through the VR headset. And well, one of the parameters that we had as part of the questionnaires was a knowledge assessment and a self-assessment goal. So we post-study, we saw some numbers that were of statistical significance that indicated patients had better knowledge of their needs. We had a few patients that actually were moving towards behavior change, which is something that we've been really looking at impacting. Behavior change, just lifestyle modifications, understanding their disease state, and why they have to take their meds and why do they have to follow certain nutrition guidelines to better their health. So some of these tools are self-administered, and what we are looking at is to take it to the next step, which is personalizing a lot of the treatment plans based on how we look at risk scores in a larger collective way. So if you're looking at a larger care coordination side type of a model, the whole idea is that better outcomes are not just related to one tool. There's no silver bullet here that we are dealing with. So one tool that may be applicable to a certain cohort may not be applicable to another. So this is a tool that we think that based on a very small sample size, again, it's I would say that it's very early in the process, but we are moving towards a 100 patient study soon. And with LEA, we expect to have a little bit more of the data, and our collaboration with American Heart, especially looking at it from a technology integration perspective as to how we can personalize a lot of the treatment plans and personalized care plans are some things that we will hopefully try to bring that in as part of this tool. So thank you very much. I hope you get a chance. We are right there in the back if you want to come and experience the tool.
Thank you so much. And our last presenter.
Things like that, like, hey, services, more money on training, give yourself some time. The same thing when you're choosing a job.
I'm Sri Vasireddy, founder of RAIN Foundation. You know, by nature we are a non-profit organization, and we talk a lot about access to healthcare, and my take on it is there is actually, thanks to all the philanthropy in the world and the governments, and there is a lot of access. In fact, I feel like the bigger problem is awareness to seek access to healthcare, and tools like Life Essential 8 are very important. And my previous presentations are about how we get this education out to get more people to seek that care. Then the next bigger problem becomes adherence to care. I feel like there's a lot of research to be done, and there's a lot of good work happening. I'm also on the Executive Advisory Committee for the Health Tech Initiative for American Heart Association. But having said that, there are very simple problems that are very difficult to do. By nature, we as human beings are, we have the right intentions to adhere, but telling somebody to take a break every day is a very simple thing to say, but very difficult thing to do. Part of what we would like to do as a foundation is to try to make that easy for patients to adhere to advice. So this is step by step. So the first step, the platform that we built is currently being used as Heart and Stroke Helper by American Heart Association. It's very simple. You can just give thumbs up, thumbs down in terms of are you adhering to your medications, nutrition, or you can dive deeper and you can enter values such as like your fruits, vegetables, and so on. And even in physical activity, you can give thumbs up, thumbs down, or integrate with your Apple Health and Google Health and keep track of all stuff. We already added the mindfulness and sleep as a part of this platform. They're already prepared for Life Essential 8. You can also see the vitals, one of the things that I'll talk about as a part of adherence is how do we make it very easy to track vitals. There's labs, and there's also symptoms tracking, and it's really, like as simple as swiping right to left is feeling worse than yesterday or better than yesterday, and then once we go through all this is the curated health journeys that Pat and team created. They can get educated on Life Essential. This is the curated content. We are the first to integrate with the care plans of American Heart Association. There are several of these for heart failure, stroke, cholesterol, hypertension, and so on. So a lot of stuff that's accessible through American Heart Association. There's also on your care plan you can get your status on how you're doing each week. Now that's good for the advanced countries, but in low resource setting, equatorial belt, a lot of people use WhatsApp, and that's one app they use, and the other apps probably don't even work on their phones. So what we've done is we've taken the existing science and protocols and made it available on WhatsApp or any platform, any conversational platform. And the beauty of this is they can interact in their own language, Spanish, Hindi, whatever it might be. So that's how we make it more accessible to the rest of the world. Now, all the data that is collected here, we have made an analytics platform available, whether you're a provider or a researcher, depending on your daily mood, weight trends, symptom trends, being able to analyze that on a weekly trend basis, drilling down from ethnicity basis, all these capabilities are there. And it takes us, really if you have some science to bring in, we can empower in days and weeks, both from a research perspective as well as collecting data perspective. And then finally, our goal is to, from an adherence perspective, we are investing in, this is a water bottle with a pill compartment, so we're talking about how difficult it is to educate people to use apps. Our goal is don't use any apps. You just go about your life, just taking medicines and drinking water, and you automatically keep adherence, right? So the idea is, how can we come up with solutions like this that makes it more equitable, more easy and convenient to adhere to the Life Essential advice, right? And everything that we do is free. The intellectual property is free. It's available online based on a MIT license. I would welcome you all to integrate, whether it is for-profit, non-profit. Our goal is to increase the impact. So, please have it. Thank you.
Thank you so much. Maybe just a brief comment, and then I want to make sure we have lots of time for great discussion. What terrific demonstrations of implementation, and I think this for me is sort of the AHA microcosm, right? We take the evidence, we take the science, we build platforms that can be catalytic, and then they're there for industry, for not-for-profits, for clinicians, for academics to work on and to make them better, but leveraging the content that AHA provides for the behavior change, for the blood sugar control. This is just so exciting to see. Yeah, Bob.
So I just want to add my thanks to the clinicians, to the entrepreneurs for getting together and trying to help all of us, including our patients. I'm going to throw my first question down to the clinicians, and then I'm going to throw my second question to the entrepreneurs. So the clinicians, and any of you can answer it, how do you decide what tools you're going to use for your patients? Derek, do you want to take a shot at it?
I think for us, it's a combination of what's practical and accessible, and we think will facilitate delivery of content to reach our objectives. And so adherence just came up in the last presentation, and one of our interventions is really focused on helping our patients who are rural to maintain their adherence to their chronic therapies. And I think that the objective comes before the design. And so that being the objective, how do we do that? We know that pamphlets, videos, teaching materials given to patients in one-offs and encounters, even nudges, such as Dr. Volp has advanced so efficiently, those have not been able to move this needle. adherence is kind of the holy grail of cardiovascular behavioral medicine and strategies to improve behavior. And so what we picked was something that we thought would be could be delivered efficiently, but also could be accessible and that could sustain a relationship with our study participants. And that way we could have a more lasting impact. We also recognize that the complexity of adherence in terms of the individual specific factors with regard to health literacy as mentioned, the disease specific factors, and also the institution, how the institution may not be facilitating adherence by the teaching of patients as well. So again, I think Dr. Harrington, the kind of summary is that objective forms the design, objective drives the design. Thank you.
Thank you.
And you were asking about the selection of content.
Yeah, how do you decide what you're gonna do for your patients?
Yes.
A lot of I mean, just here this weekend, there's a lot of choices.
Absolutely. So what I would say is the first and foremost thing that we do is we first look at the literature, the scientific literature, as clinicians. What are our guidelines? What do we need to be sending out to our population, our individual patients? Then it was actually, in our case, it was quite an extensive search. I will tell you openly, we at the VA, we have certain websites that we can and cannot go to. We are allowed to go to .govs, we can go to .orgs, but we can't really be marketing for anybody that might be for profit. So I went into a deep dive, and I can be very open about the fact that I looked at multiple sites. AHA's heart.org, time and time again, was, as I referenced, it was broad in its delivery. So we also know learners have different modalities by which they can relate to. Some are audio, some are visual, infographics, videos, and then articles. So for us, it was repeatedly landing at that very spot, heart.org, for that content and the different modalities so that we can make sure our patients can actually tap into whatever matches them best. Because we always say that. We want to meet our patients where they are and not just keep on giving them what we think they need.
Thank you. Heather? You can skip it. You want me to come back to you as one of the entrepreneurs?
I'd be best, since I'm not the cardiologist.
No, but I know you're a physiologist. You
I am.
cardiac rehab, which is critical. All right, I'll come back to you. So let me look down here, the folks that presented. And here's my question for you. How are you going to get paid for this stuff? And what do you think should be required as a level of evidence? I mean, we know what the level of evidence is in order to get a new drug on the market. You talked about digital therapeutics, Navin. How do you hope to get paid?
Yeah, so that's a great question, and I think that just being in the heart failure space, working on digital therapeutics or kind of walking in this RPM, telehealth, remote patient monitoring, obviously. So one advantage that we've had over the past years have been through the introduction of the CCM codes. So those have certainly helped align some of the incentives in terms of how we are better able to manage some of the patients that fall into this category, but more importantly, putting the right tools in the right place. So investing in something new such as immersive technology or VR-based technology, we know now that there is a workflow that we can potentially proceed, because part of the questionnaires during the study that we had, even though again it's a small sample, we had a lot of patients that did come back and say they were willing to pay out of pocket. That was a learning component for us. At the same time, I think that there's also a lot of willingness with the private payers that we're having to talk to, because this is not just one tool, this is a combination of tools. So when you're looking at a larger sort of a workflow, and this falls into part of that, monetization becomes a bit more of an easier conversation to have. So I'll end by saying, I think, over the course of the next few weeks to by the end of this year, this service is going to be rolled out in terms of a risk assessment sort of a service or a plan administered at the primary care sort of setting, so that the patients can come in and we can potentially look at this as part of the CCM workflow, so that 20 minutes of this being administered to the patient whether it is if it's a 30-day sort of a thing, 4 times a week. These sort of modalities can really work, and the delivery mechanism is very similar to like a cell phone model. You know, you have so many hours, you pay for so much of that time, and then you are able to reimburse that so that you're not bleeding.
Great, terrific, thank you. Go ahead, Heather.
This one I can answer.
All right, well, let's get you out there then.
So today, I agree those workflows exist and the telehealth codes really help with the fee schedule. But I think to really embrace this and into the future, we're looking at value-based care and at-risk and all being in that shared risk pool to really get the outcomes that we need. So we've spent a lot of time looking at what data do we need to be super meaningful to really enhance the outcomes for the patients in areas like adherence, etc., so that as the actuarials go to work on all of this data, we can really with confidence say, we're in this pool all together and we're going to enhance and advance that value-based care.
Carla, and then we'll go, Sri, you go, then Carla.
Yeah, so we've had the good fortune of rolling this out for over 3,000 patients now, and it very much is with that value-based care arrangement, working with health plans, and so we've had the benefit of the claims data for the analysis as well as the monitoring data to see the results. And so that really helps us as we continue to have more conversations in those value-based care arrangements. And we also use it not only for the explicit results of the blood pressure control and the like, but also it's a communication tool with the patient now to engage them on a whole host of quality measures that are relevant for our providers and our health plans that provides additional part of the value proposition.
Thank you, and that certainly fits with the AHA ethos of the quality feedback loop, so thank you for saying that. Sri?
Yeah, I'll actually answer both your questions because first question, how do we choose what tool to take? And as a technologist, I tell myself, don't think about a tool, technology solution at all. And more like the jobs to be done theory that Christensen introduced for disruptive innovation. What we need to think about is the unmet need of the patient or the customer in this case. And just focus on the value. So generally it's like, the famous thing is, patients don't want a 6-inch drill, they want a 6-inch hole. So to understand the patient side of it before you push something onto them, right? And how do we make money? I feel like there is so much money in the world in terms of whether it's NIH grants and Bill and Melinda Gates Foundation. If we can really find a way to make a difference in a patient's life, I just feel like money will come. And that's our philosophy from Foundation.
Great, thank you. We've got about 2 minutes left. Is there a question in the audience that somebody would like to ask?
Oh, great presentation, great conversation. My goodness, I'm totally impressed with everything that you're saying. So one of the things that comes to my mind is what tool, when you're asking that question, it's got to be personalized. If I'm a non-smoker, what is the point in me going through one of those smoking things? So we just kind of bypass that. If I don't have hypertension, I might develop hypertension moving forward, so I want to learn about that. If I'm not diabetic yet, but I might become diabetic, so I may want to learn about that. But that's personalized, so that may be one of the approaches we need to do and not do all of that. But the big one I have a question for Donald is that, hey, we're talking about nice, simple 7 first, and then we go to LE8, because now we think sleep is a very important factor, both quality and depth. But always in my mind, it's always been that if I have controlled blood pressure, diabetes, not a smoker, and I can chug along with my life and reach age 90, 92, as long as I'm not having an event. And as you said, the event is being triggered by something else. And that something else is the one that I'm going to call it the bare necessities of life 9. And the 9th factor, I strongly believe, is the psychosocial financial instability. You talk about DEI, you talk about SDOH, but then is that finance, psychosocial, and with all the technology that's available here, I feel as if, yes, we can maybe quantify the metrics in the way that we can all come up together with a metric for the psychosocial financial instability, but I think there is a tremendous opportunity for these guys to implement a therapeutic strategy utilizing all of this technology, including the VR, where the psychosocial, financial stressors are absolutely way down mitigated to the extent that we're not now triggering an event with a plaque rupture. Now we're preventing heart attack and stroke because we control the trigger to the therapeutic strategy through the immersive technology.
Love the passion, absolutely. And of course, you're dead right. And Jared was kind enough to reference this, and unfortunately we didn't show the slide, but if you look at the way we designed the 8, in the bottom is the socio-ecological model of social determinants of health, and at the top is psychological health and well-being, because that's such a filter. Both of those things, of course, are really what creates the opportunity for us to have our best cardiovascular health. But that psychological health and well-being piece is such an important filter of how the world and our lived experiences get into our body as health, as physiological health. And so I couldn't agree more. And I think if we ignore stress and psychosocial stressors and that surrounding social determinant environment, we will not succeed. And so, I would, for one, suggest that it's really hard to measure stress and how it is internalized to us, which is why we can't really go there to make the necessary 9. But again, we ignore it at our peril. And so I think that these kinds of apps that are going to focus on interventions must focus on psychological health, talk about mindfulness, talk about optimism, talk about well-being, and because those are trainable traits and they actually impact health, reduce blood pressure, do all the good things we want. So I'm right there with you. When we can measure this with one thing, I think we'll have necessary 9, and we're not quite there yet.
So I want to thank all of you for participating today. If you did, based on this last question, if you did not see Michelle Albert's presidential address yesterday, please go to the website and take a look at it. Thank you to all the entrepreneurs, thank you to the clinicians, thank you, Don, and thanks to